Hello, everybody. Welcome to a special edition of one of our IPC Partners Insight webinars, which I'm delighted to bring you in partnership with the Healthcare Infection Society. Today, we're going to be talking about something which is creating a lot of noise in the media and something which seems to be a very much evolving situation. So delighted to have Jon here today. Hi, Jon.
Hello, Phil. How you doing?
Yeah, very well. Thank you. Very well. So Jon is going to be taking us through Hantavirus, epidemiology, situation overview, and IPC implications, which we're bringing you today in partnership with the Healthcare Infection Society. So Jon, when did you first hear about the virus?
Well, Phil, I'd like to think I'm fairly well connected. I'm on a few, WhatsApp groups that gets notifications about things that are happening. But it was actually my mum. She messaged me and said, "Oh, look, there's a big outbreak on a cruise ship caused by something called hantavirus. What's all that about then?" So yeah, if you want infectious disease early warning, Mrs. Otter is the way to go. See you. How about
Right.
you?
It's just, I think, a BBC News. So I think I'd just seen an article about this outbreak on the cruise ship. And then it just seemed to be dominating the press. I think the one day I counted, there were 4 separate articles on the BBC News website about it. And I've had some really interesting conversations with friends and family about it. And actually, I think this webinar is really timely because within the public, and I reflect on my own personal experience, there are people who are really worried about this. I think that it's brought back a bit of maybe the COVID fear.
Yeah.
And as a conversation with one of my cousins, actually, and I actually sent the blog that you wrote about it to just kind of give some overview. But we were talking about reminding ourselves of the COVID pandemic and, you know, wiping down shopping bags with disinfectant
Yeah.
wipes because we were worried about transmission and, not
Yeah.
seeing grandchildren and kids within family circles for long periods of time. So yeah, it's definitely out there.
Yeah, I can see it and feel it, and to an extent in our staff as well. Frontline staff are
Okay.
asking a lot of questions and feeling a little bit anxious. So I think part of our job is just to calm people down. This is yes, it's high consequence infectious disease, certainly that the Andes hantavirus, but the risk to the general public is rated across the board by all health agencies is very low. This is not going to spiral into the next COVID. It's just not that kind of virus. So I think, as I said, part of our job is reassurance that it's a contained scenario.
Yeah, agreed. And I think that this will bring a lot of insight and knowledge to people. So just before I hand over to Jon, we always like to just run through what we're trying to achieve within these Insight webinars. This is just one in a series of Insight webinars that we run over the course of the year, and you can have a look at the schedule by scanning the QR code. As you can see, we're trying to bring an expert overview of something which is relevant within infection prevention control. I don't think you get more relevant than hantavirus. Ultimately, though, it's all about trying to generate discussion. So in the top of your screen, you'll see a Q&A. We'd love you to get questions in for Jon. This is an extremely busy webinar. We had over 600 people registered, so we're expecting a lot of discussion in the Q&A. So please get your questions in early for Jon, and I will do my best to moderate them and deliver them at the end. This webinar is also CPD accredited, so it's an opportunity for CPD. We'd like to think that we're building a bit of a network of enthusiasts, and obviously we're talking about something which is really important, but we like to try and have a little bit of fun as well. As I said, this is in partnership with Healthcare Infection Society, and we will record this webinar and we'll put it on live within the YouTube channel that we have for IPC Partners. So without further ado, Jon, looking forward to this session.
Okay, thanks, Phil. And hello, everybody. It's really good to have you join us today. I know everybody's crazy busy, so hopefully this will be a useful, quick overview session. I don't normally do this in terms of disclaimers for this sort of webinar, but I feel like I need to today, given the sort of profile of the scenario that we're talking about. And just to be clear, this is my personal view. This is not any, I'm not representing any of the organisations to which I'm affiliated. It's a fast-moving situation. What is true today is probably not going to be true for very long, both in terms of the overview of the situation, but also the guidance. I'm an IPC generalist. I haven't spent my life studying hantaviruses. So there will be people who have probably on this call. So I'm very open to correction if I've got the wrong end of the stick on something. And we've also got an international audience here. I will take a UK-centric view. That's where I'm based. But I hope that the principles that we talk through will be equally relevant wherever you're working in the world. So what I hope to do today is provide an overview of the current situation with hantavirus. Then I'll look a little bit about the epidemiology of the virus, and then think about what that means for us in terms of applied infection prevention and control in various different settings. So first up, big kudos to clinical microbiology and infection, who've managed to get a kind of commentary / review published very, very quickly, given the usual speed at which the wheels of academic publishing turn. This is a nice infographic that was correct up to the 7th of May. So this is what, one week old and already looking a bit dated. But what it does do quite nicely, I think, is put across the overview situation. So this is centered on a cruise ship that left from South America and was headed east. You can see that the disembarkation air travel has resulted in contact spread pretty much all over the world. There have been 3 deaths associated with this outbreak, and a number of different contacts, and that number is increasing all the time. The article puts across quite nicely 3, and they're at pains to point out, non-mutually exclusive hypotheses about how this this outbreak may have started on the boat. So number 1 could be animal exposure before getting on the boat. Secondly, it could be animal exposure on the boat. Thirdly, it could be secondary person-to-person spread. We now are sure there has been person-to-person spread. We've seen that as a few of the contacts who weren't on the boat have converted to cases. But as for the first 2, we're not clear on where this outbreak originated. This is the very latest data from the WHO in terms of the epicurve. So as you can see, we have now got 1, 2, 3, 4, 5, 6, 7 confirmed cases. 8 confirmed cases, maybe 7 or 8. 1, 2, 3, 4, 5, 6, 8 confirmed cases. A few probable cases. What this doesn't show, though, is the number of contacts that have been generated through this outbreak, which is quite numerous now. So I do think that over the coming 2 weeks, certainly, and perhaps up to 6, 7 weeks, we are going to see more confirmed cases as these contacts begin to develop symptoms. So hantaviruses are enveloped RNA viruses with a segmented genome. They are transmitted primarily, I mean, in general terms, almost exclusively from rodent reservoirs. They're associated with 2 main clinical syndromes in humans: hemorrhagic fever with renal syndrome, or HFRS, and that's associated with Europe and Asia, or hantavirus cardiopulmonary syndrome, HCPS, which is associated with the Americas. And we'll see in a moment, that's quite a distinct epidemiological picture for this group of viruses. HCPS is more clinically serious than HFRS. The key reservoirs for the various different types of hantavirus are shown on the screen there. So Andes virus, that we'll talk about in more detail as we go through this webinar, is mostly associated with long-tailed pygmy rat in South America. So the global distribution of hantaviruses is hung very much on the global distribution of the rodents, which is why we see such a clear global distribution of the 2 different the 2 different main syndromes associated with serious hantavirus infection. So this is driven by climate, by rodent population, by human exposure to rural environments. Those are the 3 main kind of drivers of incidence of the kind of the background hantavirus situation. We see different regional patterns with different types of hantavirus in terms of the kind of background epidemiology. And that is manifest in the symptoms or the serious infections that are caused, with HCPS really exclusively appearing in the Americas and HFRS in Europe and Asia. So clinical features of a hantavirus infection, it begins with a febrile phase, non-specific early symptoms, fever, chills, myalgia, sometimes GI symptoms as well, which can occur within 3 to 5 days. Now, this is a problem because, of course, these are very non-specific. People have these sort of symptoms all the time, and then that can develop into cardiopulmonary involvement in HCPS or renal involvement in HFRS. And that can develop into shock and severe cases. And we see severe disease manifested in a number of different ways, depending on whether it's a HCPS or HFRS. Neurological involvement has been reported, but it's rare. The mortality of HCPS can be up to 30–40%. Now, that's caveated by the fact that our case detection in the outbreaks that have occurred to date or around background cases of hantavirus infection probably isn't great. So in terms of case fatality rate, because we're not capturing the low-grade symptoms, it's probably lower than that when it comes to a whole picture of case fatality. So we know that the virus linked to the cruise ship is the Andes virus, and that is quite different to the other hantaviruses. So geographically linked to South America, as we've seen, associated with HCPS. Unusually for hantaviruses, there is limited evidence of cross-transmission, and we've seen before the case fatality can be up to 35%. All hantaviruses are associated primarily with the rodent reservoir, and because of that evidence of person-to-person spread, the level of concern around the Andes hantavirus is significantly higher, to the extent that in the UK, the Andes virus specifically is classified as an airborne high consequence infectious disease, HCID, whereas other hantaviruses are not. So thinking about incubation period, the numbers often cited are between 4 and 40 days. 40 days is a long time for potential incubation, and we'll come back to that in a moment. The median incubation is 18 days following exposure, and this reflects differences in the viral strain, exposure, dose, and also host factors. And the relationship between those three, and probably other factors, is not well understood. This is based on limited epidemiological data. And so this gives us a really long monitoring period required for contacts. So in terms of a period of infectiousness, well, it's a bit of a misnomer really for most hantaviruses, because there's no human-to-human transmission risk at all, so not considered infectious. For the Andes virus, transmission has been reported during that early prodromal symptomatic phase. Pre-symptomatic transmission, as far as I know, and as I said, I'm open to correction, has not been reported, but it is possible. And for that reason, the latest NHS guidance suggests that we should work on the basis of infectivity 2 days prior to symptom onset, and that's to cover the risk of this pre-symptomatic transmission risk. At the other end of an infection, we don't understand much about the duration of infectiveness, and I hope that during this outbreak we'll get some better data on that. And again, much like the previous data, we are limited by the evidence base. So because of this transmission risk during the early symptomatic phase, early isolation is going to be critical for reducing the risk of secondary cases. So is transmission primarily this is zoonoses? So it's contact with aerosolized rodent excretia, urine, feces, saliva. Other possible routes include direct contact with rodents. I have seen some evidence that the rodent bites can result in an infection being initiated, and probably contaminated surfaces as well as direct contact with excretia. The Andes virus, as we've seen already, stands apart from the other hantaviruses in that prolonged close contact transmission has been reported. As far as I'm aware, there haven't been any cases of sort of incidental contact resulting in a transmission. This has been prolonged close contact, likely via respiratory secretions. So we're just going to look in a little bit more detail at two examples where evidence for human-to-human transmission has been published. This is now a famous publication in the New England Journal of Medicine from 2020, so 20 years ago now. No, 26 years ago, get the year right. Relating to an older outbreak of the Andes hantavirus in Argentina, which involved 34 cases, 11 deaths. Unusually for hantaviruses, this was characterized by sustained person-to-person spread. And you can see in the figure there, in the top right-hand corner of that figure, there's 4 generations of human-to-human spread that were tracked through descriptive epidemiology. Now, this seems like an unusual level of spread for the Andes hantavirus, and it seems to be driven by 3 so-called super spreader events in crowded social settings. Some epidemiology showed us that high transmission risk was linked to high viral load, not surprisingly, and liver injury as well, but not viral mutation itself. Now, the reproduction number was just a little bit more than 2 in this outbreak, and it was reduced to less than 1 after straightforward control measures were applied. That feels quite high, and probably my sense is that's not representative of most outbreaks. I think as per the title of this article, there was some super spreader events involved, but it does highlight the importance of close contact, social contact, and early control measures being effective in reducing the spread of the Andes hantavirus. So our second example, I've chosen because it includes some evidence of nosocomial transmission, that is transmission in a hospital setting. So this was a cluster of 5 cases with an index case linked to rodents and 4 secondary cases. Clearly cross transmission based on the microbiology of the viruses involved. So the 4 secondary cases, 2 were household contacts and 2 were linked to hospitals and healthcare workers. So it's some strong evidence that we need to be careful in protecting healthcare workers from exposure. And you can see transmission was linked again to prolonged close contact, but during that febrile prodrome. And caregiving, bed handling, and kissing was involved. Now, I hope that the kissing was not linked to the healthcare workers providing care. I'm pretty sure that was probably the household contact. So just very, very broadly, this is broad brush. Don't take too much away from this, but it's just helpful, I think, to contextualize transmissibility of various organisms. So measles is sort of the queen king of transmissibility with an R naught approaching 20. Followed by varicella zoster virus. SARS-CoV-2, there's a big range depending on strain type. Pandemic influenza, certainly more than 2. Seasonal influenza, probably less than 2. The Andes hantavirus, based on that New England Journal of Medicine, comes in at 2. But as I said, my sense is it's not as transmissible as seasonal influenza. But we hopefully will see that come out in the evidence linked to this outbreak. And of course, the other hantaviruses aren't even on the chart, just non-transmissible. Okay, before we get to thinking about IPC interventions and preventing spread in a healthcare setting, a quick look at surface survival and inactivation. Despite being an envelope virus, and we know envelope viruses are less robust in the environment than non-envelope viruses, the Andes hantavirus can survive on surfaces on stainless steel surfaces in a lab for up to 5 days, but the half-life is 24 hours, so they're losing half of their viability every 24 hours. Alcohol-based hand rubs, very effective. All of the tested surface disinfectants of various chemistries achieve complete inactivation. So the Andes hantavirus is certainly more susceptible to disinfectants than non-envelope viruses, and even more so than most other envelope viruses. So it's not a big environmental survivor, which in some ways is slightly surprising, given that its primary route of transmission is probably linked to sort of an environmental type reservoir. Okay, I'm going to move on to think about IPC guidance now. So 2 days ago, the NHS published some guidance for the prevention control of the Andes hantavirus in health and care settings. So this is an infographic that I produced to summarize kind of the high-level points of the guidance. In the bottom right of this slide, there's also an example of one of the 4 action cards that's published alongside the guidance, which are useful to look at and help us to understand actions to take in an ED, emergency department setting, inpatient, outpatient, and what to do with contacts. So this guidance is hung on the outbreak of the cruise. We know that the Andes hantavirus can spread person to person, hence the need for this guidance and the HCID classification. The guidance includes details on case definitions. It also includes details on containment levels from a lab point of view and a waste point of view. The guidance, when I looked at it earlier, said category A. I understand that's going to change to category B for some of the recommendations. There's also some specific requirements for asymptomatic contacts that we'll look at in a sec. Reference to the hierarchy of controls we'd expect to see. Details about PPE for patients and for staff, ensuring we have negative pressure isolation, recommendations around cleaning and disinfection, and also some specific recommendations around visitors. Clearly, managing our visitors was a big theme of the COVID pandemic, and I think something that we learned from that we should try and facilitate visitors to the extent that is possible. And I think this guidance is reassuringly permissive on the fact that we should try and facilitate visiting, even with viruses with serious consequences. But of course, we need to be careful. So hierarchy of controls is something that we're being asked to think about a lot, and rightly so, because the more we can think about elimination, removing the hazard, the better. So, for example, rather than bringing a patient in for assessment, what can we do remotely? Those are the sorts of things that we should be thinking to try and reduce our risk. And at the bottom of the pyramid, the least effective and the most risky controls relate to PPE. So case definitions, the guidance includes possible, probable and confirmed cases. And you can see the breakdown of the clinical criteria. So this is in the context of symptomatic cases that had some degree of contact with the cruise ship. And the distinguishing factor of the confirmed cases, you've got that laboratory PCR positive combined with that travel or contact history. The guidance also includes action for asymptomatic contacts that we'll look at in a sec. And in terms of diagnostics in the UK, this will be directed by the UK Imported Fever Service. So the recommendation is, if you have a patient that meets one of these case definitions, get on the phone and you'll be given support as to which samples to take and how to get them off to Ripple, which is the Rare and Imported Pathogens Lab for testing. So PPE, let's briefly run down the PPE for asymptomatic contacts. The suggestion is we go with airborne PPE, so that's single gloves, disposable long sleeve gown, a full face visor and a fit tested FFP3 that's also fit checked as standard. For confirmed or suspected cases in the community, airborne PPE is recommended. And for suspected or confirmed cases in a healthcare setting, the gold standard being presented to us is the unified HCID PPE ensemble, both for suspected and confirmed cases. If that's not available in your setting, then as a minimum, airborne PPE must be used, with a couple of additions, including a head covering and fluid repellent footwear, such as clogs or wellies, to kind of cover the risk that there's a big body fluid spillage that may be highly infectious. Okay, so cleaning disinfection, we know already, we've looked at it before, the Andes hantavirus is susceptible to a range of disinfectants that are commonly used in healthcare settings. In this guidance, it goes down the route of 2 rounds of cleaning and disinfection required for suspected and confirmed cases in any care setting. 10,000 parts per million available chlorine solution is recommended as sort of the first line disinfectant. with alcohol as the second line, that there may be other options that are available locally that you could think about. For reuse of medical equipment, it's either the chlorine or the alcohol solution, so it's not first line, second line. It seems to be presented as either or. And just to note, fumigation is recommended for confirmed cases in non-HCID units. It's not clear what fumigation means. I think that would be managed on a case-by-case basis. So key actions, I think, to make sure that you've got covered, if not already, is get your clinical pathways sorted. What happens if you have a patient with travel history, exciting travel history linked to this outbreak, and symptoms turns up at your front door? What would you do? Early symptom recognition, travel history, we need to make sure we're promoting this to our frontline clinicians all the time, but especially in the context of this outbreak. Be up to date on the case definitions. Think about PPE. The guidance is quite clear on the recommendation to use a non-valved FFP3 mask for patients who are contacts or suspected or confirmed cases. That's kind of a new recommendation to me. I understand the logic. And make sure staff are briefed on local PPE decisions as well if there's any deviation from the national guidance. And environmental cleaning and disinfection, I think we're given a steer by the national guidance, but you need to be clear that you have a local plan in place. So finally, in terms of research priorities, there's exciting opportunities presented by this outbreak for us to learn about person-to-person transmission dynamics, about infectiousness, about infectivity, and also I think the prevalence of low-grade symptoms. What I expect to see is we will see a better detection of lower grade symptoms, which will help us to qualify the impact of serious infection with the Hantavirus. I'm not sure whether we'll have an opportunity to really understand the impact of treatment. There maybe won't be enough symptomatic individuals that require treatment, but I'm sure some treatment will be used and we'll get some information from that. It's a prompt, as always, to get some vaccine development on the go, and to think about the effectiveness of the various IPC interventions that we've talked about. So Phil, I'm finished. Back to you.
Thanks very much, Jon. Fascinating and a huge amount of content in there. Lots of people online and lots of questions as well. So thanks very much, Jon. Like I said, learned a lot. Maybe, Jon, I can start with testing. There's a question specifically around like turnaround time in a reference laboratory, which I don't think we'll be able to answer, but maybe just share with the audience about, is there a certain test that is done for determining whether or not if somebody is positive or negative?
Yeah, so we've got for an asymptomatic contact, the guidance lays out a specific testing regime. So we're asking for weekly swabs and blood samples that will be sent off for PCR, and also serum testing. And for confirmed cases, it will depend on the symptoms, but ultimately it will be those samples that will go to the lab for PCR, with PCR being the gold standard from a diagnostic point of view.
Thanks, Jon. And that has the benefit of turning the test around quite quickly. Yeah,
exactly. I mean, yes, the process doesn't take long, but obviously depends on sample transport and laboratory capacity as well.
Thanks. Okay, going to try and filter through lots of questions. There's a question here about PPE, Jon, and there's a comment that it's different in a acute versus a community setting. Is there any rationale for that, do you know?
Yeah, I think probably part of the rationale for that is around what's happening with the patients. In an acute care setting, we are giving more invasive procedures, increasing the transmission risk as a result. There's probably also some pragmatic advice in that it's just not possible to get a full ensemble out into every setting. So the PP guidance that's been put in, I think we can have a lot of confidence in. It's come with consultation across various different committees, and it's well thought out. And I think there's recognition that whilst a full HCID ensemble for suspected and confirmed cases is seen as this kind of ultimate aim, there's a recognition that's not available everywhere, and this guidance is making safe and effective PPE recommendations in that context too.
Understood. Thanks, John. Well summarised. So one of the things that struck me from the presentation was incubation period, and how that could be up to almost 40 days. There's a question here in the chat about, people who have been contacts, how often are you continuing to test them for if they're asymptomatic? Is there guidance on that yet?
Yeah, I mean, the NHS guidance that we've hung this on today doesn't talk about the duration of isolation of a contact, as far as I can recall. But it's going to be a conservative approach. We want to wait until the end of that 40 days before we're letting people out of isolation effectively, if they're a high-risk contact.
Understood. There's a question from Gavin, and you touched upon this in terms of environmental survival. Should we be worried about environmental survival of the organism, in the healthcare environment? And then maybe you can link that into what that means for cleaning and disinfection.
Yeah, I mean, I think if we were to ask this question 20 years ago, would an envelope virus survive on a surface? Many people would say it would be dead in a couple of minutes. That was the feeling back then. It's changed now. We have much better recognition of the capacity of even a kind of an organism not known for environmental survival, like a non-envelope virus. It can survive for days on a surface, and that's more than long enough to be linked to cross-transmission through contact with that surface. So I think that the environmental survival data shows to me that we need to focus on the environment as much as we need to focus on early detection, travel history, good diagnostics, good patient placement. We need to look at surface cleaning and disinfection in the round of all of those things. We know that this virus is not resistant. It does not have reduced susceptibility to normal hospital grade disinfectants. So whilst the guidance is focused on 1,000 parts per million available chlorine, practically speaking, there are other solutions that would be effective. Now, it's an organizational level decision as to how you manage that, whether you feel the risk of changing process is greater than sticking with current process.
Understood. There's a question specifically about suitability of hydrogen peroxide, and I think I can answer that for you, that would be extremely effective against an envelope virus.
Yeah, I agree with that. Clean disinfection. One thing to note is that no disinfectant works well on a dirty surface. So we always have to have a clean surface for a disinfectant to work on. Now, this set of guidance, like the national IPC manual, says you can either do that by 2 rounds, so by a cleaning round followed by a specific disinfection round, or a combined cleaner disinfectant. So my sense is that a combined cleaner disinfectant is a much better approach, because to ask somebody to get really good coverage of a detergent and then really good coverage again of a disinfectant is a big ask. And it gets even harder in this context because this guidance recommends 2 rounds of the process. So to fulfill it with a 2-step process, you'd be clean, disinfect. So sort of 4 applications of something to a surface feels like a very big ask. So if we can halve that to 2, that feels like a win.
Yeah, definitely. It's challenging the kind of human behavior side of being able to clean things so many times, and ideally to try and cut down and simplify the process definitely would benefit. Lisa is asking about travel. So I think in the presentation, you talked about travel history and you referenced an outbreak in Argentina, but I think that was a long time ago now.
Yeah.
What is there any specific guidance on countries, where we should be worried about this because of higher incidence?
Yes. So the specific history that we are looking for here is either somebody who's been on the boat, who is a direct contact of somebody who's been on the boat, or somebody who has been in a UK overseas territory, linked to the boat. So some people disembarked on some of the islands that are part of UK overseas territory.
Okay, thanks, John. Really well explained. I'll stick with another question from Lisa if I can. Lisa asks if a member of staff had contact with a suspected case prior to donning the relevant PPE, would they isolate until the result is known?
Yeah, they would. They become a high risk contact in that case. I think as is the case with kind of standard application of PPE, if you've got appropriate PPE and no evidence of a breach, then you're not a contact and you carry on as is. But if there's any PPE breach or inappropriate levels of PPE, then you would become a contact. And for this situation, you would be required to go home and stay there until your isolation period had expired.
And do you know what the isolation period is, Jon?
Well, I said it's probably going to be 40 days, but I'm not sure on the exact detail of that.
Okay, it's an awful long time, isn't it?
Yeah, it's a long time. You think about that as the proportion of a year.
Yeah,
Not some Netflix.
yeah, lots of Netflix. Do you have a feel for how those patients or contacts who are isolating are being monitored? Is it being monitored with a really high level of scrutiny and compliance?
Yeah, I mean, I think everybody so far that I've heard about that is a contact and isolating at home is complying with the regular screening and the isolation. So I think people are getting it, and that's a good thing.
Yeah, agreed. There's lots of questions around, when patients are considered non-infectious. So if somebody has active infection, again, guidelines on that yet, or still evolving case by case?
Yeah, I really struggle to find data on this. So if anybody knows of any data on period of infectiousness for hantavirus in general, but specifically the Andis hantavirus, I'd be all for it because I struggle to find anything to kind of inform that decision. It may be that we don't know, and we'll find out during the course of this outbreak.
Thanks. There's a really helpful comment in the chat from Martin saying about they've had a contact and their isolation period for them was 45 days.
That makes sense. And yeah, so just over kind of the maximum that's usually reported. I think it's right for us to be conservative, because this is such a contained situation, and we're not expecting to see big transmission outside of those who are either on the boat or one degree of separation from the boat.
Agreed. Yeah, really helpful. Thanks, Jon. Lots of queries kind of challenging some of this guidance around cleaning and disinfection and the need to, clean a surface or clean and disinfect a surface multiple times. Maybe just re-highlight, Jon, what your advice was there around, how you might think about simplifying that cleaning and disinfection process.
Yeah, I mean, the guidance gives us the option of a two-step cleaning process where you clean first and then disinfect, or a combined cleaning disinfectant. So I think having a cleaner disinfectant approach saves you kind of a step, and if you multiply that by 2, then it saves you 2 steps. So I think a combined clean disinfectant would definitely help.
Fab. Lots of people asking about whether or not the slides will be available. So the recording will be available on the IPC Partners YouTube channel. So you'll be able to share that and watch it again. Where there's also questions, Jon, around, we're obviously monitoring contacts now, but do you have a personal sense of, where you think this outbreak or this is heading? Do you think that we're going to see lots of more positive cases pop up, or you think that given the precautions that we're putting in place and the monitoring and the tracking of contacts, that this will hopefully start to fade away?
I'll just get out my crystal ball and have a look at it to answer that question. I don't know. Nobody knows. So what does the evidence tell us? The evidence tells us that once straightforward biocontainment measures are implemented, Andis hantavirus doesn't spread. So I think we can be really, really sure that now that we're on it and that the kind of healthcare systems are in full swing, I'd be very surprised if we had any other secondary transmission now. Perhaps there may be a nosocomial transmission if somebody needs care, but relatively small. What we don't know is the extent of exposure to those already on the ship. So we know there's a number of contacts, so my prediction is we will see more cases as contacts convert over the next 2 to 3 weeks, and some of those will become serious. That's just the nature of the virus. But I'd be surprised if we saw really any more than 1 or 2 isolated incidents of secondary transmission from this point forward.
Thanks, Jon. There's a question around a definition for a contact, and I think you had that really nice table. So I don't know if you just want to touch on that briefly.
Yeah. So the guidance talks about high-risk contacts, and those aren't completely defined in this set of guidance. But what it does say is that a contact in the context of this guidance is considered a close contact within 2 meters. So being in the other side of a crowded room from somebody is not considered enough to make you a close contact. You're required to have
Understood. Thanks.
closer proximity for a period of time.
Thanks. There's a question here about staph exposure in the laboratory. If it's treated as category 3, but there's contact with different sample types from a patient found to be positive after initial samples are processed. Presumably aerolized processes might lead to staph isolation.
Yeah, so we need to think that through carefully. Obviously, samples from suspected cases should be managed in containment level 3. So I think any inadvertent exposure in the lab would be a failure of process, like any other organism. I mean, even if it's not containment level 3, there are processes in place to make sure lab staff aren't exposed at lower containment levels. But if there was an exposure, you would be looking at a period of self-isolation for sure.
Thanks, Jon. I think we've probably got time for one more question. Question from Yassine here. Hi, Yassine. Good to see you. People who have been identified as contacts, are they going to specialist centres or are they allowed being able to self-isolate at home? I don't know if you can comment on that.
Asymptomatic contacts, as far as are being managed. There's a group of them that's being managed up in Arrow Park.
Yeah.
And some others, are being managed in the community.
Thanks, Jon. Final one, I think. You talked about close contact. Is there a time frame linked to that? So you'd have to be in that close contact for a prolonged period of time, or is it just saying that if it is close contact, you meet the kind of requirement and that requires isolation with somebody who is symptomatic?
Yeah, so going back to the evidence certainly includes time in terms of risk. So it's prolonged close contact, not transient close contact. The guidance as written only talks about a 2 meter radius. So I think probably what the current approach is any duration of time in close proximity is enough to make you a contact, with a recognition that that's probably quite a conservative approach in terms of the risk of spread.
Great. Thanks, Jon. We're going to have to leave it there, I'm afraid. We've got a couple more slides just to share to run through. Thank you all for so many questions. I'm really sorry that we didn't get to all of them. Just shows the importance of trying to get them in the chat early. So Jon, huge thank you. Appreciate that was put together in a very much emerging and evolving situation. So yeah, we've just got a couple of slides if you can advance us on, Jon, to talk about. So our next IPC Partners Journal Club, we're delighted to welcome, talking about how everyday actions and everyday language shape infection prevention and antimicrobial resistant outcomes. I've read the papers that Jules and Claire will be running through, and they are really interesting, particularly around the language we use and what that means for how we work and interact with the public from an IPC perspective. So you can join us next Wednesday for that. So that'll be here soon. That's where you can subscribe. This will take you through to a subscription link where you will get regular information from IPC Partners around our journal clubs and insight webinars, and also blogs. We publish blogs, usually 1 or 2 every week. We've blogged on Hantavirus, and we've blogged on upcoming journal clubs and webinars as well. So please make sure you check out that link as well. And finally, we just have some messages from our partners, the Healthcare Infection Society. There's a webinar series with Mr. or Professor, I think, Chris Whitty, Infection Specialist Workforce Report. That's on the 3rd of June at 12 o'clock, so you can join that. And also advertising a wonderful conference up in Glasgow in November, FIS International 2026. Registration for that is now open, and there'll be plenty of information there and sessions around high consequence infectious disease, HSID, so links really nicely to what we've been talking about. So please do check out that website for signing up for HIS. Before that, though, you've got the chance to go to HISCon, so it's very much kind of conference season coming up after or before the summer and after the summer break. Jon and I will both be at HISCon in London. I've attended the last couple of years, and it's a fantastic conference. It's hosted at the Royal College of Physicians in London, and it's over 2 days between the 23rd and the 24th of June, and there are some great talks. I think that is everything. So we're 1 minute over time. Jon, huge thank you again for putting that together. Really informative, lots of praise from the chat, and please make sure that you check out our sponsors' websites. Thanks, Jon.
Thanks, Phil. Thanks everyone for joining. Bye for now.
Bye.